Welcome everyone to today's installment of the PPHA webinar series. I'm so excited to be joined by Adrienne Shanker, the Executive Director of the Bradbury Sullivan LGBT Community Center. We're in store for, I think, a really exciting and informative presentation today. As always, this will be recorded and posted to our YouTube channel after the presentation. Please post any questions you have in the chat and we'll save some time for a moderated discussion at the end. Adrienne, you can take it away. Thank you.
Great. Thank you so much, Brooke and PPHA. Proud to be a member of PPHA, and it's so great to join you all today. I'm going to share my screen and where did that guy go? You should be able to see the screen share now. If you can't, Brooke, you can let me know if there's any issues with that. But by way of introduction, I'm Adrienne Shanker, he, him pronouns, and I'm zooming into you from unceded Lenape land in Allentown, Pennsylvania. And by way of access, I'm a white man with kind of a checkered shirt sitting in front of plants in my apartment. And we're going to be talking today about patient narratives or healthcare consumer narratives and how we can merge that with data to address barriers to care. And we're going to be able to discuss what barriers to care are, recognize tangible opportunities to address barriers to care, and the hope is that that can impact patient care as well. And also by way of introduction, I lead Bradbury Sullivan LGBT Community Center, which is located in Allentown and provides arts, health, youth, and pride programs to celebrate and support LGBTQ+ people, especially in the Lehigh Valley, but across Pennsylvania. We also administer Pennsylvania's biannual LGBTQ health needs assessment, and we actually do that in partnership with PHMC. And I see that Jen Keith is here today. Jen is the person that leads the analysis for that report. So a lot of this will be review for her because I have some of the data points in there as well. More info about us is at bradburysullivancenter.org. And I always like to start any webinar or presentation in person or virtual that I do by recognizing that we can't fight for health equity for LGBTQ people and ignore the fact that we are on colonized and stolen land. So again, I'm zooming to you from Lenape land, unceded Lenape land in Allentown. Melanie K. Kantrowitz says that solidarity is the political version of love. So if we're going to fight for health equity, we can do it from that place of solidarity. And health equity, of course, is defined by HHS as the attainment of the highest quality of health for all people. Of course, health equity is an unmet dream that LGBTQ people have not yet achieved. We lack health equity in all areas of our life due to barriers to care and outright discrimination. And of course, that's also impacted by social determinants and even political determinants of health, including transportation, violence, food insecurity, housing insecurity, discrimination. All of these lead to worsened health outcomes and direct inequities. Just a couple other introductory points before we get into the patient narratives. Stigma is one of the biggest reasons that we experience worsened health outcomes. Sean Strube says that stigma is about other people making a moral judgment about your worth. And stigma leads to worsened health outcomes for either delaying or avoiding seeking care, discomfort discussing certain health topics with a clinician. A patient knowledge gap as well is often grounded in stigma, missed opportunities for early detection and treatment. And Sean Strube, who wrote this definition, was one of the early leaders of ACT UP New York. He's a longtime HIV activist. The Pennsylvania Patient Safety Authority, which is an independent regulatory agency that regulates hospitals, abortion clinics, and ambulatory surgical facilities across Pennsylvania, said last year that it is a patient safety issue if LGBTQ people delay or avoid seeking care because of fear of mistreatment. They will hold hospitals, for example, accountable to that definition. So it counts as a patient safety issue if LGBTQ people delay or avoid seeking care because of fear of mistreatment. And of course, that's what we know happens all the time. LGBTQ healthcare consumers, and we are all healthcare consumers, repeatedly encounter negative experiences when accessing the healthcare that our body needs. This leads many LGBT patients to delay or avoid seeking the care that our body needs due to that fear of mistreatment. Also, queer patients may be unsure which providers are welcoming in their community, and healthcare professionals don't always know about the past negative experiences that their patients have had. So when we look at what barriers to care are, what we're talking about are literal stumbling blocks that can be geographic, clinical, behavioral, or structural. And they literally are stumbling blocks in our pathway to achieve health equity. I started working on this book, Bodies and Barriers, Queer Activists on Health, after I had a negative experience with a dermatologist that I'll tell you about in a minute. But this book is an edited volume of 26 essays by 26 LGBTQ activists from around the world who are telling our stories about experiences navigating the broken healthcare system so that healthcare providers and public health folks can hear us and hopefully change this system that was never created to serve us. It was created to serve the majority population, and that's what we ended up with. So really, these stories are about how the public health space and the healthcare delivery space can hear patient needs directly from patients, because it's never really okay to ask a patient to teach a provider. So this volume is really about providing that information directly. I'm going to start with my own story, and then I'm going to share some stories from other contributing authors. I'm a full-time queer activist leading an LGBT community-based nonprofit organization with a focus on LGBT health equity, and it happened to me too. By it, I mean a negative experience with a healthcare professional because of my queer identity. I made an appointment with a dermatologist for a baseline screening for skin cancer, but at every turn, the doctor's well-intentioned team made me question if I should be there at all. The intake forms were unnecessarily restrictive. Biased news programming was on full display in the waiting room. Magazines in the waiting room didn't cater to patients like me, and comments from clinic staff displayed brazen cultural incompetence. I didn't go back for the doctor recommended follow-up. I'm privileged with health insurance, access to private transportation, and the ability to take time away from my job to make a second medical appointment. So I was able to find a new LGBT inclusive dermatologist an hour away. For many other LGBT consumers of healthcare, the geographic barrier to accessing culturally appropriate LGBT inclusive care from a specialist might be too great a barrier to overcome. When I was a graduate student at George Washington University in their LGBT health policy and practice program, I was struck by the lack of literature written by healthcare consumers and activists to inform healthcare professionals and students and health professionals about the unique health needs faced by the LGBT population. Throughout our lives, LGBT people experience unique structural barriers to care that lead to higher risk behaviors for numerous sexually transmitted and chronic diseases. When compounded with past negative experiences in healthcare settings, including outright discrimination, LGBT people experience worse health outcomes than the majority population. This isn't our fault. A 14-year-old youth program participant from Whitman Walker Health Clinic in Washington, D.C. shared that wellness is about surviving in a world that wasn't created for you. And that's what LGBT people have bravely been doing for decades: surviving conversion therapy, surviving family rejection, surviving discrimination. To be sure, not everyone survived, not by a long shot. No conversation on LGBT health is complete without an acknowledgement of the pain: the loss of a generation to AIDS, the loss of 49 queer lives at Pulse, the loss of so many queer bodies to homicide, suicide, substance overdose, and hate crimes. And with acknowledging pain, we should acknowledge that survival is a privilege, that the chances of surviving are higher for white, higher income cisgender men. Those who survive our unfair landscape persevere through barriers at every step of the way. Barriers from the government, medical establishment, pharmaceutical industry, insurance companies. We live with increased tobacco, alcohol, and other drug usage. We live with increased risk for obesity and diabetes. We live with increased risk for chronic diseases, including HIV and cancer. We live with increased discrimination, violence, harassment, and bullying. We live with family rejection and minority stress, and we are demanding that our healthcare systems respond to our lived experiences with culturally appropriate care at all stages of our lives. So that's a little bit from my story. I'm going to share some other folks' stories. The first one is from Elisa Bowman. Elisa is a parent of a child who at the time was in second grade. And Elisa writes, "When I learned that my second grader was transgender, I found myself explaining over and over again to a long list of people who my child was. My parents, my husband's parents, my siblings, extended family, teachers, administrators, friends, child's friends, parents of child's friends. It went on and on. One person I didn't bother to tell was my child's pediatrician. I ghosted him instead. At the time, I didn't even know why. I'd never heard anyone in the particular doctor's office say anything offensive. Yet I just couldn't shake the feeling that my son's doctor would either be completely uninformed, best case scenario, or openly hostile, worst case scenario. Now, years later, with the benefit of hindsight, I know precisely what made me uneasy. It had nothing to do with what my son's doctor said or did. Rather, it had everything to do with what he did not say or do. Talk to us about our child's gender. My transgender son had never behaved, presented himself, or carried himself like a typical girl. By second grade, his short hair was nearly buzzed and he wore ties and only allowed me to shop for him in the boys section of the department store. His hobbies centered on watching World Wrestling Entertainment, memorizing Pokemon characters, and playing Bakugan and kickball. His transness was on full display and loudly noticeable to just about anyone with the slightest inkling of the science of gender diversity. During several doctor visits, I'd even mentioned telling signs, how my child refused to go to the bathroom at school, for example. There had been plenty of openings, but our pediatrician never once asked us questions about our son's gender, nor suggested that our child might be trans. It was akin to treating a child with high blood sugar and never once saying anything to the child's parents about type 1 diabetes. The next story that I'm going to share is from Emmett Patterson. Emmett is originally a Pennsylvanian and lives in Washington, D.C. now. Is a transmasculine young adult who shares his experience trying to access sex ed information as a transmasculine youth at the time that this was discussing. So Emmett writes, I know what it's like when curricula and medical institutions are not structured around your sexual and gender related needs. These experiences built my consciousness around health inequities and pushed me to develop my own skills as an educator and activist. As a young person living in a rural community outside of Pittsburgh, Pennsylvania, coming out as a trans man to my family and community brought a number of challenges to my sexual health. In my mandated year of psychotherapy that I completed to receive approval for hormone therapy and other trans-related care, countless providers ignored discussing my sexual and reproductive health. The first time I was asked if I had thought about becoming pregnant in the future was right after my primary care physician placed my first hormone shot in my hands. My providers seemed to not be bothered to think about, or perhaps couldn't imagine, a trans person being sexual, which prevented them from assessing what some of my sexual health concerns might be. So I stayed silent and researched on my own, struggling to find myself in news stories about teen pregnancy and deciphering if HPV vaccine guidelines applied to trans men. The next story is from Laura Jacobs. Laura is a healthcare professional as well as a healthcare consumer, as all healthcare professionals would also be healthcare consumers. And Laura writes about her experience visiting an ear, nose, and throat doctor. And before I share Laura's story, we don't often think about certain medical specialties as areas where we would need LGBTQ competence. When I went to that dermatologist and I had that really bad experience, I talked to my mom afterwards. My mom said, well, why does it matter if your dermatologist is like LGBT friendly? And I said, well, Mom, it's not like gay people have skin. Like, we actually need good care for all parts of our bodies. That would include, in Laura's case, ear, nose, and throat related care too. So her story starts in quotes. Laura is a transgender. Didn't the surgeons do an amazing job? You'd never know, said the specialist to the intern as I sat fully clothed on the exam table. I heard the sanitary paper crinkle as my legs dangled over the edge, awkwardly childlike. Every trans-identified person I've ever met has experienced it. A medical interaction during which we felt fetishized or insulted, when a provider used insensitive or inappropriate language, where a professional pried for information not relevant to the clinical issue. Rather than encouraging a bond, these moments only amplified the resistance. My sleep had progressed from poor to worse. I spun in the bed, drifting into the beginnings of sleep, but then never falling further or maybe waking abruptly and being unable to fall asleep again. The ragged, inconsistent rest I did get was hardly enough. Each day I swam through the fog, barely alert. My work suffered and I had little energy to enjoy life. I began seeing Dr. B, an ear, nose, and throat doctor and sleep specialist, several months earlier to evaluate allergies, medication side effects, environmental issues, diet, stress, or anything else. We determined that the adenoid and terminate membranes inside my sinuses were swollen and possibly had been for quite some time. My tonsils were also inflamed. As a result, my breathing was uneven. I sniffled and struggled to get enough oxygen. The airflow interrupted by enlarged tissue shrinking the passages. Minor surgery scheduled for a month or two ahead would open the airway. But we were there for pre-surgical consult, and never in any of our visits had I been undressed. I wanted to list the annoyances as my consciousness spun. No one is a transgender. We're transgender people, beings for whom a quirk of biology, spirituality, or a yearning to explore the human experience through the lens of gender felt the desire or need to live in a way other than how we were born. Some of us have altered our bodies, others not. We've each thought at length about how we define our identities, and our language choices are deeply personal, intended to reflect our nuanced understanding of ourselves. We're also not a monolithic group solely defined by our genders, but a diverse set of people for whom gender is just one of the many facets of who we are. A simple question about what terminology was best would have been appreciated. She also disclosed without asking permission. I had indicated my transness on the intake form and had mentioned it in the initial evaluations unashamed. But other than the possibility that the estrogen had affected my sinuses, which had already been ruled out, my being trans was irrelevant, and telling the intern served no purpose. Instead, the doctor outed me without consent or need, raising the issue at the beginning of the interaction, framed my identity to the intern solely in terms of my gender, as though I was little else. The amazing job done by the surgeon's remark was less about my identity than about my body, but I had never undergone surgery to my face, so she could only be referring to the neck down. I felt an onrush of anxiety. Why were my genitals the subject of an examination of my sinuses? Not only had she just told the intern what I had down there, but what I used to have, and that it made a decision to be altered from one to another. Why? What business was it of the intern? The room suddenly felt too warm. The next story is from Katie Dahlk. I tried to pick a bunch of Pennsylvanians. Katie is in Hershey, Pennsylvania, and shares her experience as an intersex person who dealt with problematic healthcare as a child. So at age 6, I underwent a routine hernia operation. My surgeon and parents were shocked to discover that in place of ovaries and a uterus, my pelvis carried internal testes. A karyotype confirmed that my sex chromosomes were XY instead of the typical female XX. My diagnosis, which would later be known as complete androgen insensitivity syndrome, reflected my body's inability to respond to the androgens that my testes had produced during fetal development, shifting me instead down a usual, in quotes, female pathway. The next 10 years were excruciating for me and my family. My physician, a well-respected pediatric endocrinologist, followed a then standard medical practice recommending that my parents never disclose to me my diagnosis, chromosomes, or gonads. Intersex patients who knew, they feared, would question their gender identity and sexual orientation or commit suicide. And so my family adhered diligently to the prescription of total secrecy, each of us internalizing the message that there was something wrong or shameful about my natural body. It wasn't until we found the androgen insensitivity syndrome differences of sex development support group that my family could begin to visualize a future in which I knew all the details of my condition, and I was loved and happy for being different. Here's another story is from Robin Oakes. Robin's a bisexual activist in Boston, and her story is actually called Without Wincing or Clenching: Bisexual People's Experiences with Healthcare Providers. And Robin writes, "My name is Robin Oakes, and I've identified as bisexual for 42 years. I'm an educator, advocate, and healthcare consumer. What do I want my healthcare providers to know about my experience as a bi person accessing healthcare? The first thing I want them to know is that even after all these years, the thought of telling a healthcare professional that I identify as bisexual fills me with anxiety." When I was in my 20s, during an annual checkup with a new primary care physician, we had the following conversation. The physician asked, "Are you sexually active?" And I responded, "Yes." The physician said, "What kind of birth control do you use?" At the time, I was in a monogamous relationship with a woman. I wanted to reply flippantly, "We use the lesbian method," but I wasn't that brave. I hemmed and hawed and squirmed uncomfortably and finally managed to state that my partner is a woman. It was awkward and uncomfortable. A couple of years later, that relationship had ended, and I was in a new relationship with a man. I suspected that there was a note in my chart saying I was a lesbian, and I finally awkwardly told my doctor I'm bisexual and got fitted for a diaphragm. Is it just me, or are my experiences commonplace? Are my experiences unique? Yes and no, but mostly no. So that's a little bit of just some narratives from Bodies and Barriers, Queer Activists on Health. I will share the link to this book in the chat once I complete the screen share, but it is a very accessible book. It's all written as first-person narratives to help public health folks, healthcare consumers, policymakers, healthcare providers all work together to try to improve care. I'm going to match this with health disparity information so that you all have a good understanding of how health disparity data and healthcare consumer narratives can work together to improve care. So first, all of these data are from the 2020 Pennsylvania LGBTQ Health Needs Assessment. And again, I want to give a special shout out to Jen Keith, who's on this call, who did all of the wonderful analysis with her team at PHMC's Research and Evaluation Group. But 1 in 3 LGBTQ Pennsylvanians fear seeking healthcare because of past or potential negative reactions from providers. And that's even when we looked at Black, Indigenous, other people of color who are also LGBTQ Pennsylvanians, 1 in 5 of them experienced a negative reaction from a provider because of their race. So when we overlap that, we see intersectional health challenges. 1 in 5 LGBTQ Pennsylvanians receive insurance through medical assistance, such as Medicaid, Medicare, or CHIP, and 1 in 10 are prevented from seeking care because affirming providers are not covered by their insurance. 1 in 10 queer Pennsylvanians are prevented from seeking care because their providers that are affirming are too far away. And other barriers include finances, language, transportation, time, and being able to even identify LGBTQ affirming providers. When we look at some specific healthcare experiences, nearly a quarter have experienced a negative reaction from a healthcare provider based on their LGBTQ identity. And 1 in 4 have not disclosed their identity to any of their providers at all. We say that to treat me, you have to know who I am. Providers can't provide great care if they don't know the risk behaviors of their patients, and they may not know to ask certain questions without understanding sexual orientation and gender identity of their patients. More than 1 in 10 are prevented from seeking care because their providers are too far away. 1 in 10 are prevented from seeking care because providers aren't covered by their health insurance. And more than a third do not believe that most of their healthcare providers have the medical expertise related to LGBTQ health. Medical expertise, not cultural competency, medical expertise, more than a third. That's a shocking number. When we look at mental health for LGBTQ Pennsylvanians, just as a snapshot, 1 in 5 report that they never or rarely receive the social or emotional support that they need. Never or rarely. 37.2% often or always feel isolated. And by the way, these data were collected at the beginning of the COVID pandemic from March through May of last year. However, the numbers are not that dissimilar from the 2018 survey when we looked at mental health. So while it was taken during a period of quarantine, I actually don't believe that it is significantly different from what we would see, for example, next year when we redo this. 7 in 10 LGBTQ Pennsylvanians experienced a mental health challenge in the past year, and 3 of those 7 have not received counseling or mental health treatment. And 9 in 10 LGBTQ Pennsylvanians under age 18 have experienced a mental health challenge in the last year. And again, last year is a look back starting in March 2020. So we're talking about March 2019 to March 2020, not during the pandemic for that question. Lifetime experiences with suicide, more than 56% of LGBTQ Pennsylvanians have had during their lifetime thoughts of suicide, and 53% have had thoughts of self-harm. When we look at basic needs, 1 in 5 LGBTQ Pennsylvanians have experienced homelessness at some point in their lives, and more than a third, or close to a third, often or sometimes worried whether their food would run out before they got money to buy more. More than 40% have just enough or not enough money left over at the end of the month. and over 60% have experienced discrimination based on their LGBTQ identity at some point in their lives. It's worth stating that Pennsylvania and across the country, we do not have comprehensive enduring protections from discrimination. This is an area of advocacy that public health professionals can work toward to advance LGBTQ health, is to also advance our right to access housing and public accommodations without fear of discrimination. When we asked LGBTQ Pennsylvanians, what's one thing you'd like to tell your healthcare providers to be more welcoming? We heard a variety of answers, including be honest with us, ask everyone their pronouns, don't assume everyone's cisgender, I would add, or heterosexual. Be more welcoming to the trans community. Educate yourself, meaning don't expect your patient to educate the provider. We received so many responses, but many of them were really about how providers need to do better. They need to learn, they need to study and become people who LGBTQ folks feel comfortable going to for care. Some clinical changes that could help us include data collection on LGBTQ demographic data. So on the surveillance data side, this is really important. As public health professionals, you're all familiar with BRFIS, Behavioral Risk Factor Surveillance System. There was a vote at the HHS level where all the states got to vote this year on if they should add sexual orientation and gender identity into the core survey, and it was actually voted down. So states have to self-fund adding sexual orientation and gender identity into BRFIS. That's just one example of the problematic ways that data is collected and excludes LGBTQ people every step of the way. And that's only one survey. The US Census also has excluded LGBTQ demographic data. So we don't have a lot of surveillance data, but when researchers are conducting their own surveillance data, it's really important to collect sexual orientation and gender identity demographics within all of those data collection processes. Intake forms are unnecessarily restrictive at the clinic level, and forms should include expansive gender options, appropriate pronouns, chosen names, and should avoid gendered questions about past medical procedures, such as, if you're a woman, please answer these questions that are about pregnancy or breast cancer or things like that. Instead, ask people about body parts and procedures, not about their gender. Waiting rooms should, they're one of the first things people notice even before the intake form. And waiting rooms should reflect a diverse patient population. There are super secret symbols like rainbow flags, posting a clinic's non-discrimination policy and providing LGBTQ magazines go a long way in making healthcare consumers that are part of the LGBT community feel welcome. And of course, clinical training, we would always advocate that clinicians especially, but all healthcare providers and public health folks dedicate continuing ed time to learning about LGBTQ healthcare topics. And that clinicians in particular should prioritize medical skill building as they complete their CMEs. Cultural competency is important. We really need providers to have the medical skills. For example, in much of Pennsylvania, it is a 6-month wait or more to get access to an appointment to a provider who can prescribe PrEP or pre-exposure prophylaxis, preventative HIV medicine. There's literally no reason why every primary care doctor couldn't do that. If they know how to manage blood work, they should be able to do this. But in many parts of the state, there is over a 6-month wait. Assistant Secretary of Health, Dr. Rachel Levine, our former Pennsylvania Secretary of Health, wrote the foreword to Bodies and Barriers. And in her foreword, she wrote, as a physician, I've seen the health consequences of neglecting a patient's needs. As a policymaker, I've seen the cost of creating policies that are uninformed. And as a transgender woman, I've felt the burden of others' ignorance. The saying is true that we haven't made progress unless we've all made progress. Some additional promising practices for removing barriers to care include engaging trusted messenger strategies. So LGBTQ organizations and leaders can help dispel misinformation, or in the case of COVID vaccine, disinformation, and build trust in vaccines and other public health initiatives. The right providers are also important. So For example, we'll talk about vaccines for a minute. At the beginning of the vaccine distribution effort, the providers were very large public health bureaus and hospitals. But we heard repeatedly from especially transgender Pennsylvanians who did not want to go to those agencies for their vaccine because they had to put their legal name into a website to schedule, and then they were going to show up and possibly be outed in front of hundreds of people when their when their name didn't look like who they were. So it's important to partner with the right providers, which includes LGBTQ specific healthcare providers. Training for healthcare professionals and affirming care, health disparities, barriers to care, and accessible healthcare services, so off-site health services at community centers and pride celebrations. We see this outlined in our needs assessment data. We also see it anecdotally throughout our community. For example, flu vaccines are about to, we're entering flu season, or we've recently entered flu season, and we're bringing flu vaccines to Bradbury Sullivan LGBT Community Center in Allentown as one site where people can go to receive flu vaccines. That way they don't have to go to a traditional healthcare space for it. And that's kind of a model that should be happening around our state. Again, Pennsylvania Patient Safety Authority defines it as a patient safety issue if LGBTQ people delay or avoid seeking care because of fear of mistreatment. And with that, I'm happy to enter into questions and discussion. I'm going to stop the screen share, and I'll put my email in the chat as well as the link to the book. And sorry, the color gradient window, I couldn't see the chat when I had the screen share. So I apologize that it was blocking part of the slides. It wasn't visible on my side. I'm happy to share the slides with PPHA if that's helpful afterwards, so that some of you who might have missed part of that can access it.
Thank you so much for the presentation. I really enjoyed how you started off by sharing the personal narratives of LGBTQ patients who have experienced this. And I felt like it provided a lot of context to the data that was later on in the presentation. Is there anyone in the audience who would like to ask a question? You can either post it in the chat or unmute yourself. You're welcome to ask it yourself.
And while people are thinking about any questions they may have, I'll just comment on what you just said, Brooke. So that's literally the reason I edited Bodies and Barriers, because there is data, but the data without context doesn't always lead us to the right results. So data without context sometimes leads us to, for example, a hospital saying, oh, this is how we can solve that problem, without actually hearing how patients were experiencing that problem. So I think it's really important that we balance the data with cultural experiences that healthcare consumers have had. That allows fuller context when public health experts, policymakers in government or health insurance or health networks or clinicians are working to address these challenges.
Hi, Adrienne. It's so great to see you. Thank you so much. Always good to hear about the book and the data. I wanted to see if you could talk a little bit more about how folks and agencies and organizations can partner with LGBTQ focused organizations to improve and to take some action steps. I know that's been a recommendation that you and I talk about with a lot of folks, but I think it's helpful when folks kind of leave with that tip of like, you don't have to feel overwhelmed. There's a lot of steps you can take.
Yeah, thank you, Jen. That's one of the primary recommendations in the Pennsylvania LGBTQ Health Needs Assessment is partnerships between public health and or healthcare providers with LGBTQ community-based organizations. And the reason that's so important is because LGBTQ organizations on the community level, they may not be experts in healthcare, and they don't have to be experts in healthcare, but they are absolutely experts in their own community, right? So if you're a public health agency working in York, Pennsylvania, for example, and you want to better understand how LGBTQ people are hearing information about flu vaccines, what better way to get that info than to partner with the LGBT Center in York, help them by providing them with someone who can provide the vaccines on site, and let them market it to their community with a language that they think will help to reach the people that are target population. Essentially, you're allowing them to be a trusted messenger. And that's a model that really works, is partnerships. I would suggest that if it's a long-term partnership, it should be funded. If it's a one-time thing, like we have to do a couple flu shot clinics or things like that, simply providing the vaccines and some technical assistance might be enough. But in general, we do advocate that these partnerships should be equitable for the community-based agencies. There's a lot of expertise on our own community, in our own community, and it's valuable to tap into that. It also means that you don't have to reinvent the wheel. You don't have to try to develop an LGBT. We don't need healthcare providers to be experts on LGBTQ communities. We need you to partner with us, right? That we need you to talk to us. And same on the public health end. Like in the disability rights movement, there's a saying, nothing about us without us. And I think that's really true for all historically excluded and minoritized populations. Decisions about minoritized populations should involve people from that community in at least the discussion, if not the decision-making itself. So thank you, Jen. That was a great question. If there's any other questions, you are welcome to unmute yourself. You're welcome to type it into the chat. And I'll also mention that if there's interest in multiple copies of Bodies and Barriers for like a clinic or for a public health department, I'm able to get like deeply discounted bulk copies as well. If there's, I believe it's at least 10 copies, but I can check on that. So my email is in the chat, and that's something we've done with like a couple of the municipal health bureaus and other stuff along those lines. If there's any
put
other,
that in our newsletter as well.
oh, great.
To reach out to you because there are a lot of people I think that are really interested in improving their knowledge in this area who might not be on the call today.
Yeah, I can get you some language for that for sure.
Yeah, that'd be great.
I'm also open to questions about things I didn't say or things you may not want to ask to non-LGBTQ people. So if there's any questions, it's very welcome. If there aren't questions, it's totally okay also. Okay, well, it was very nice to spend some time with all of you today. I'll stay on with Brooke for maybe like another minute or two in case there's any questions that someone wanted to ask individually.
Thank you so much, Adrian, for really powerful and informative conversation. I know I really enjoyed it.
Just checking in, Olivia, Alia, Lori, if there's any individual questions, I'm happy to answer. Otherwise, thank you so much for joining today. Okay, well, have a great day.
Thanks so much. Bye-bye.